As a humanitarian professional, you are always in progress, always working, always looking for ways to increase your capacity and advance your career. We help you get there. Learn on the go regardless of location, time or schedule. Simply log in to any of your devices, enroll for a course and begin enhancing your skills. Some of the areas we cover include monitoring, evaluation, accountability and learning, water, sanitation and hygiene, disaster risk reduction and management, food security and nutrition in emergencies, procurement and supply chain management, human nutrition and dietetics, maternal and infant young child nutrition. Join us today to enjoy a 10% discount.
Maternal and infant young child nutrition webinar. And today's topic is addressing common concerns in breastfeeding. Our key speaker for the day is a nutrition expert, Annette Mambo. And part of the agenda of today's webinar will be optimal breastfeeding for the infant and young child, and breastfeeding practices for stay-at-home and working mothers. Once again, I welcome you to today's webinar, and I really encourage you to engage with us, talk to us. You can begin by letting us know where you're joining from. Just say hello to everyone. Let us know where you're joining us from today. You can also share if you're interested in getting any information, any more information. It could be on nutrition or any other course. You can also let us know, and we'll be able to address or assist you. Our team will be able to reach out to you. So before I welcome the HG Humanitarian Global team to say hello, I'd like to start with a few house rules. So house rule number one, make good use of the chat section and the Q&A section. So you can always reach out to us in case if you have anything, any comment, reach out to us on the chat section. And I already see, hi Peter, hi Jamal, hi Matut. I already see people actually quite active and engaging on the chat section. So thank you for that. If in case you have a question related to today's topic on breastfeeding, again, just to repeat today's topic, addressing common concerns in breastfeeding. This is a maternal, infant and young child nutrition webinar. And in case if you have any questions on anything that's going to be talked about today, put the question in the Q&A section, and at the end of our expert's presentation, she'll be able to address some of the questions that we do ask. There will be a Q&A section. So also within this Q&A section, I'll ask some participants to speak and ask questions. So during this segment, kindly do raise your hand, use the raise hand feature, and we'll allow you to talk. With that, I'd like to welcome the Humanitarian Global team. We are actually quite a big team here. So we could start with Anthony. Anthony, you can say hello to everyone.
Thank you so much, Diana, and also hello to all the participants connected to this particular Zoom session. We're so happy to have you on board for this meeting. And as we continue, as we always say, try to share the link with your fellow colleagues and also friends, so that they can also get to join and follow up with the same session with us today. So my name is Anthony Mkui from Humanitarian Global Academic Support Team. So my role here within this particular Zoom session is to ensure that you can get our audio connection, the presentations. So in case you have any technical challenge, you can chat with me, and I'll be there to assist you. So thank you so much, and looking forward to a great session. So back to you, Diana.
Thank you, Anthony. We also have Ian. Ian, you can say hello to the team.
Thank you so much, Diana. Hello, everyone, and thank you for joining this session today. We're really looking forward to learn more from our expert of the day. And for any questions or clarifications, as mentioned, let's engage on the chat and the Q&A section. Thank you so much.
Thank you so much. And from everyone else behind the scenes working to ensure this webinar is a success, I do send my greetings on their behalf. I'd like to welcome Annette just to say hello. She'll come back on later to talk about today's topic. Annette, you can say hello to everyone.
Thank you, Diana. Hello, everybody. My name is Annette Mambo. I am your today's presenter. I'm a nutritionist, and I hope to have a very interactive session. Thank you for now.
Thank you so much. And I am Diana, I'm the Academics and Training Coordinator here at Humanitarian Global. And for today, I am your moderator for this webinar. Before I welcome Annette on, I'd just like to touch on something that actually Annette will also touch on. So remember, this is a webinar for humanitarians, those in development and aid fields. And with that, I'd like to introduce to you a course that Humanitarian Global, through its innovative approach and feedback system, has been able to develop, and it's beginning in August. So this is an online course. The mode of learning, just before I talk about the course itself, is going to be through virtual classroom through Zoom. So it's similar as being in a classroom, only difference is you're doing it online. And the reason behind this is so that you can be engaging continuously with the trainer. You can have interactive sessions with your fellow participants as well. For these courses, we usually take a number of maximum 10, and it's based on first come, first serve basis. So for this one, we are beginning with the orientation on the 4th of August. So it begins in August, which is in around 2 weeks' time. So in 2 weeks' time, we'll begin this course. And the course itself is called Humanitarian Essentials and Principles. It's going to take us 4 weeks to cover this course. And just to touch on something else before I just talk a little bit about the course, is part of the mode of learning is going to be evening classes, whereas we understand that you have a busy schedule during the day, you're working during the day, you have your day-to-day life schedule. So we don't pull you away from that. So what we do is we have evening classes. This is the virtual classroom via Zoom. And for that, we are able to now even engage you, and we're able to interact with you without having you forgo what your normal activities, be it work, be it business, be it school, even during the day is. So like I've mentioned, the course itself is Humanitarian Essentials and Principles. And these Humanitarian Essentials and Principles are actually what all non-governmental organizations, international agencies, international NGOs, community-based organizations, faith-based organizations as well, all organizations, be it the UN, be it Red Cross, be it International Resource Committee, any organization that works in humanitarian aid, in response to crisis, follows these humanitarian essentials and principles. And so you're going to be able to learn about them. So depending, even whatever field you're in, you could be a nurse, you could be a doctor, you could be an accountant, you could be a project manager, you could be an assistant, for instance, you could be an admin assistant as well. So whatever work that you're currently doing, whatever career you're doing, learning about the humanitarian essentials and principles, it's actually mandatory for those who work in non-governmental organizations, who work in the humanitarian field, who work in works, who also want to work in fields that deliver aid and respond to crisis. So the Humanitarian Essentials and Principles talks about the core humanitarian. We begin with talking about the humanitarian principles, first of all. So the humanitarian principles, you get to learn more about what they are. You get to learn about the impartiality of the work that you do, the timely response of the work that you're going to be able to do, and so on and so forth. Then You get to learn now about the core humanitarian standards, which are commitments. There are 9 of them, 9 commitments that organizations, like I've told you about, do follow in order for them to deliver their work efficiently. And as someone who wants to work in the humanitarian section, it's like I told you, it's actually now becoming mandatory for you to be able to not just be aware of these 9 commitments, but also understand them and understand how they interact with each other, and as well as the humanitarian principles. So like I've mentioned, we are offering this course, and this course is not just for those people in humanitarian aid development field. It's also for those of us who want to get into that field, for those of us who want to work in humanitarian aid development. Maybe you want to work in an NGO, even in government. Now, remember, government works hand in hand with the NGOs in order to implement programs and projects. So if you're interested in taking this course, like I have mentioned, it starts in early August, 4th of August is when our orientation is. You simply come and click on apply now. And if you'd like even to find out more about this course, you can also send a request. And when you click on apply now, you get a form that appears, such as what you can see on the screen, and you register for the course. Once you send in the registration form, you submit, our team reaches out to you and assists you through the payment process, as well as registering for the course. The course itself costs $250 for the 1 month that you're going to be undertaking. And at the end of this 1 month, you're going to get digital certification in humanitarian essentials and principles. And this digital certification is facilitated by HPAS. So HPAS is a resource for those of us who work in NGOs, those of us who work in humanitarian field. So all professional courses are actually hosted, or rather, their certification is facilitated by HPAS. And the reason for this is it opens up your visibility to recruiters, to organizations, to even potential employers, because your details, whenever you receive, for instance, if you receive a certificate from Humanitarian Global on humanitarian essentials and principles, when someone is looking for someone with skills, specific skills in humanitarian essentials and principles, they are able to go on this platform. And when they simply search humanitarian essentials and principles, then they'll be able to see, for instance, Diana does have skills in this and has been certified in humanitarian essentials and principles. Something else about the kind of certification that you do receive. So this certification is actually quite detailed. It's a 3-page long certificate, whereas just to talk about some of the things you'll see in this certificate is you're able to see the exact skills you acquired, the exact modules you undertook. You know, a lot of times, a lot of people give certificates on, probably they'll give you, like when you talk about humanitarian essentials and principles, they'll do a bit of an introductory and then give you a certificate. Whereas you have a certificate, you really don't have an in-depth understanding. You don't have the skills when it comes, for instance, to the core humanitarian standard. You're not aware of it. So with this kind of certification here, it's very detailed, and it's actually now what organizations are leaning towards when it comes to professional courses and their certification, is that they're able to see the exact skills you acquired, the exact modules you are able to undertake, whatever you are able to learn. So like I mentioned, $250. The course is 1 month, virtual classroom. I welcome you. In case if you're not, we're going to be sharing the details of this page that I was casting. In case if you're not able to register today, you can share your details with us. I see we've already shared on how to apply for this course. In case if you're not able to, share your details with us. Only us, whenever you chat with us, only us who are hosting this webinar are able to see. So there is data privacy. So you can share your name, your phone number, and your email address, and just let us know you'd like to apply for the Humanitarian Essentials and Principles course, and then we'll be able to assist you. With that, I just wanted to mention a little bit about that course because it touches on everything, including nutrition. Now, I'd like to welcome Annette. I'd like to welcome our speaker for the day, Annette. And today's topic, like I did mention, addressing common concerns in breastfeeding. And she's going to be talking about two main things: optimal breastfeeding for the infant and the young child. This is from birth to 24 months. And best breastfeeding practices for stay-at-home and working mothers. With that, I'd like to welcome Annette. Annette, the floor is yours. The team is yours, so you can take over. Welcome, Annette.
Hello again, everybody. I would like to begin by sharing my screen. So I hope it's visible to everybody. So today's topic, as we have heard, is addressing the common concerns in breastfeeding. And I'm going to move a little bit faster, but if you have any question, just ask in our question and answer, and we will address them. So to begin with this, we have already talked about what our topic is going to be. We are going to be looking at an agenda that is going to help us know and help mothers in the best breastfeeding practices, and also to help babies have optimal breastfeeding so that they can be fully nourished and they can have all the benefits. So there is a small introduction here, which I will not dwell so much, because by now, if you are in this humanitarian sector, we know that breastfeeding has been recommended to all parents, to all mothers, for the first 6 months. It is the best option for both the mothers and the babies, and it should take place exclusively, meaning that there should be nothing else other than breast milk, not even water, for the infant for the first 6 months of their life. And this should continue, the breastfeeding should continue even when now the mother introduces complementary food, and it should be a part, the breast milk should be a part of the diet until the baby is about 24 months, that is 2 years old, or at least 1 year. So it's a very important journey that both the mothers and the child undertake, and it takes practice for both the mother and the child to have a hang on it so that it can be good for both of them. So today, we'll be addressing some of the concerns, some of the worries that mothers have in connection to breastfeeding. And today we deal with the normal mothers, the normal child. We have special circumstances. We have children who have been born to mothers who are sick. We have children who have been born with birth defects. We have birth complications. We have medical conditions. We are not dealing with those today. We are just dealing the normal mother with the normal health, with her normal kid with the normal health. So in another session, we'll be dealing with those complications. So first of all, we'll introduce ourselves to a small overview of the breastfeeding process. There are some notes there, but I'll just talk about them. So this breastfeeding process, it's also called as lactation. Lactation is where the mother produces breast milk, which should be fed to the baby to provide their nutrients and other benefits. So this process involves two main processes, that is making the milk and releasing it. And these two processes are controlled in two main ways. That is the hormonal controls by the hormones, and also the autocrine, or the local control. We are going to understand what that is. So in pregnancy, once a lady becomes pregnant, there is a placenta that develops. And one of the roles of this placenta is to generate hormones. So there are many, many hormones that are generated. Today, I'll just mention about 3 or 4 of them, which have direct involvement with breast milk production. And I'll mention the estrogen, the progesterone, prolactin, and also oxytocin. Now, this placenta generates this hormone from the time the mother is pregnant. So estrogen and progesterone are very important hormones. First of all, they usually they support the pregnancy by making sure that there is no preterm labor. and there is no miscarriage, and in breast milk production, they start causing the growth and the development of the glandular tissue. Now, everybody has mammary glands, both the men and the women, the breasts, but in women, during pregnancy, the high levels of estrogen and progesterone that are produced by the placenta, they cause the development of the milk-making tissues in the mother. So as the pregnancy grows, the glandular tissue, those milk-making tissues also develop in readiness to feed the baby after birth. Another hormone that is also produced during this time is the prolactin, and this one, its role is to directly produce milk. Now, as long as estrogen and progesterone levels are high, even if the prolactin produces milk during pregnancy, the estrogen and progesterone inhibits the milk from being released or being produced in a lot of amount, because we don't want a pregnant mother to start releasing the milk. So at birth, when the estrogen and progesterone levels drop, because when the uterus separates from the placenta, and we are saying the placenta is the one that produces these hormones, then the progesterone and the estrogen levels go down, and then now the prolactin can now be able to produce the milk. I just also want to mention that the early milk called colostrum, which is very thick and yellow and rich in antibodies, in hormone and nutrients, starts being produced in pregnancy at around the 16th week of pregnancy by the prolactin. And at birth, it is already available, although at very small volumes, usually measured in teaspoons, but it is already sufficient for the very new, the newborn baby. So breast will start producing the milk, the mature milk that we know now, at about 2 to 3 days or 30 to 40 hours after birth. And this milk now is supposed to be sufficient enough to feed the baby throughout for 2 years or even more for those mothers who are interested in breastfeeding. So there is some notes there that you could read. So today, and now I start with this, the common concerns in breastfeeding. I want to note that there are so many, so we are just addressing a few of them. And because breastfeeding is a two-way process where the mother has her role and the baby also has its role, it takes two of them for breastfeeding to occur. We are going to see that these processes interplay. So we cannot just have the role for the baby alone and the role for the mother. It takes two. So we are going to discuss these concerns as commonly affecting both of them. So they are as follows. So one concern is called delayed onset of lactation. Now, just imagine a situation where a birth has come, and during the first few hours or the first few days, the mother has not yet started to produce the milk. Now the mother is very concerned what her baby is going to feed. So I want to just tell you so that you can also share with the mothers that this is not a very dangerous situation, because remember we said colostrum is produced in pregnancy. So even if there is no milk, as there is no a lot of milk coming to begin with, that little amount of colostrum that is there, the mother should try to initiate breastfeeding as early as possible and put the baby on the breast. We'll see how to do that. And then the baby can, that little colostrum is sufficient for the baby for the first hours of its birth, because it's very, very rich in some nutrients and antibodies and hormones that will help the baby to get adjusted to the outside world. So even if the milk does not come in immediately after birth, of which naturally, biologically, it does not happen, the colostrum is sufficient enough for the first few hours. However, if after the third day the milk has not yet come, then it becomes a real concern. We are concerned if the baby now will survive, because the colostrum has already started dwindling, and there is no now anything to feed the baby. So some of the things that the mother should do to ensure that she does not have the delayed onset of lactation is to establish early breastfeeding. That is, we call it early initiation to breastfeeding immediately after birth. If it's a normal birth, the first hour within birth, she should put the baby at the breast, because the earlier she starts breastfeeding, the more the breastfeeding hormones are produced, and the faster the milk is going to come. And then we also encourage, where the baby is unable to breastfeed, the mother can try manual expression. You know, expressing of milk means pressing the nipple, and there's a way that is done, and removing the milk, not just by the baby suckling, but by expressing it from there. So the more you remove the milk, the more you encourage another milk to be formed. So that's what we encourage. Now, skin to skin contact. We always talk skin to skin. And when we say skin to skin, it means the baby's skin should be touching the mother's skin. The hormone called oxytocin is a let down hormone, where it helps the milk that has been produced in the breast come to be released from the breast. So this hormone that sends these signals that it is time now to release the milk, one of the way to stimulate it is the skin to skin contact. It's a feel good hormone that is produced when the mother comes in contact with her newborn. And the more oxytocin there is, the more let down, or the more release of milk to the child there is. So that is why we encourage this to happen. Now, in case milk is still not coming, we encourage the mother to use a warm pad or a heated pad, where she can dip a cloth in some warm water and massage her breast, or have a warm shower, and then she can try expressing or breastfeeding the baby. And she should also avoid stress, because other hormones also usually have an effect in breastfeeding. The cortisol, that stress hormone, usually inhibit the prolactin and the oxytocin, which are involved in producing and releasing the milk. So the higher the stress, the higher the cortisol levels, the more they inhibit this milk production and releasing milk. So we need the mother to sleep so that she can be rested, and to also listen to some music or do some things that make her happy. So I've dealt so much on this so that we can understand how we can help these mothers. Now, if the milk is very late in coming, we need to do supplementing of breastfeeding. And the most recommended thing is the use of human donor milk or formula. Is the human donor milk in a hospital or in a health center setup is the best. Do not do it at home there, because remember, breast milk from one mother could contain some disease-causing organism that could go to the other mother. So not unless the milk has been screened and pasteurized or treated for use by other babies, it should not happen in our villages, in the houses. It should be in a health setup where there is a milk that has been treated. Alternatively, we could use newborn infant formula, because remember, infant formulas, they come with ages, to supplement if the mother milk is very late in coming. And we'll know if the baby starts losing excess weight, the baby has started becoming dehydrated, it's jaundiced. If we look at its poop and we see the meconium, that is the baby is already born with some waste products in the system that are greenish, blackish, some funny color. If this has not yet changed to the nice yellow color that we know from the breast milk poop, then we know that the baby is not getting, the baby is now ready to have a meal, so we can supplement. However, as we continue to supplement, the mother is encouraged to put the baby at the breast, latch the baby, and let the baby try to suckle, because it helps to stimulate the mother to produce prolactin, the hormone that is producing the milk, and also oxytocin that helps the let down. And if the baby is not, you could also try to hand express the milk, and any milk that is expressed can always be fed to the baby first, and then supplemented with the donor or formula milk. Remember, even if there is no milk, it's very important to keep the baby well fed, because that is the only way that the baby is going to survive. Now, what about if the milk is coming, but the mother is concerned that it is little, that there is low breast milk production? Mothers who are concerned that they do not have enough breast milk. So, first of all, remember, always tell these mothers, always let's be aware that breast milk production is a process that is supply and demand. The more you supply, the more is produced. The more you breastfeed, the more you express, the more is produced. So to make sure that there is enough milk, we will advise mothers to initiate breastfeeding early. To room in, that is why we put the mother and the child in the same room. They stay there for 24 hours. As long as possible, they are staying together so that, oxytocin to be released. The more close, when the mother sees the baby, the mother hears the baby cry, oxytocin is produced and it helps her to release milk, and also easy access to the baby. You don't have to put the baby in another room where the mother has to go upstairs, downstairs, right and left, looking for the baby. We advise that they stay in the same room. And then we are saying breastfeed exclusively. Don't give the baby any other thing, because this will cause the baby to use the breast milk less. And remember, we have said the more milk is used, the more is produced. And we are saying this exclusive breastfeeding should not only be done during the day, actually during the night, around 2 to 5 a.m., that is early morning, that is when we have the highest level of prolactin. So the baby should be fed then. Mothers should be told not to worry. Another reason why prolactin is important is it helps mother, it also has an effect on sleep. A mother is able to wake up and breastfeed and go back to sleep immediately. That prolactin also causes the mother to feel sleepy. So whenever you're not breastfeeding and express the milk regularly, massage the breast to stimulate them to bring down the milk. We have said it's important to breastfeed frequently and on demand. Do not have a schedule. Do not say at 8 a.m., at 10 p.m. or 9, anytime the baby wants, on demand. Give them the breast, sometimes even for the comfort, to encourage these hormones to be there. And then always the correct positioning and attaching to the breast is very important, because that is the only way to effectively remove milk from the breast. And the more you remove, I'm saying the more it is produced. Skin to skin contact, we said, also helps in the production of oxytocin, the letdown. And then there is another thing that mothers should always be told. If they want more milk, they must create time for breastfeeding. Take your time to breastfeed and make sure that the breasts are emptied completely. Do not breastfeed halfway and then jump to the other breast. Make sure the more you empty the breast, the more it will fill up in the next production of the milk. And then the others, we are saying, if the baby does not want to suckle, make sure that you can express the milk and feed the baby. And then avoid using the things that can confuse the baby from the nipple. Avoid using bottles, pouted cups, those cups with a thing that the baby can suck there. And even pacifiers, they confuse the baby. Remember, they are not exactly like the nipple. So sometimes the baby can be confused whether these things and the nipple of which to stick to. So avoid using. If you express a breast milk, use a spoon and a cup to feed the baby. If the baby is very young, use a syringe. You just drain some milk using a syringe, and then you put it in the baby's mouth, just the baby, how using a syringe. And then to make sure that the milk is enough, also, the mother has to have enough variety of a diet to make sure that the food is nutritious and enough liquids, and also to make sure that the milk she's producing is nutritious. We have talked about stress. and being very tired. This will cause a lot of cortisol, and cortisol is an antagonist or inhibits the production of the hormones that help in production of milk. Now, another concern for mothers is if the baby's breastfeeding skills are good. The mother always, especially first-time mother, is wondering, is my baby able to suckle effectively and sufficiently? So, good clues for the mothers to know that milk transfer, that is, she's transferring her milk effectively to the baby, is to have to look and listen for swallows of the colostrum or the milk. So the mother has to be keen, look to see if the baby is swallowing and listen. If there is deep swallows, then she knows, yeah, there is milk that is being suckled. And then she can also watch the jaw for the active sucking, and also she can monitor the amount of poop. You know, what comes in goes out. So if very little is going out, it means the baby is not having enough breast milk to suckle, and then the baby is not suckling enough. And therefore, now she can now try to address that. Now, we are also having a point there that is telling us that milk removal is the most efficient when a baby has a good mouthful of breast tissue as well as the nipple. Now, there is this thing that to advise mothers on how to latch their babies and how to position their babies so that the baby now can be able to effectively breastfeed or suckle. We also need to ensure that the baby has enough stamina. The baby is not sick, the baby is happy, the baby doesn't have a wet diaper, enough stamina so that they can be able to have energy to breastfeed. It's also a process that requires energy. Now, in case the baby cannot breastfeed, hand expressing or using a manual pump or electric pump can be more helpful. It can help the mother to remove the milk and feed the baby, and it will benefit them both. Now, we said that it is very important in the breastfeeding process for both the mother and the baby to have a deep latch. That means a mother should attach the baby to the breast well. So the mother will know the signs of good attachment are when there is a comfortable experience with no pain. If there is pain on the nipple or the breast, it could be because there is no good attachment. The more areola is visible above the baby's mouth than below. Areola is that dark part of the breast. So if we look at the picture beside here, we can see it's not just the nipple in the mouth, it's a part of the breast tissue, including the areola that is in the mouth. And you are being told the baby's mouth should be wide open. You can see here that this mouth of the baby is very wide open. It's not just partly open. Their lower lip is turned out. And you can see the chin. Also, another good sign of breastfeeding is that their chin here is nearly touching, or sometimes touches or nearly touching the breast. That is a good latch. I have to mention that in my experience, so many mothers have problems when it comes to them helping their babies to latch. So it is our role, we as people in this field, to help mothers to be able to latch their babies well. I also have a picture here of showing a picture, the bad one. I want you to focus on the bad one. The bad latch is, you can see the baby is just attached to the nipple. You can see all those things that we were saying. The chin is not touching the lower part of the breast. The baby's mouth is not on the areola. The baby is just like hanging on the nipple. That is very, very wrong. So when the baby is attached properly, the nipple is deep in the mouth, and you can see the milk flow in the first picture. B, you can see that when the nipple is deep in the mouth, the milk that is produced from the glandular tissue, it moves very fast in the ducts and into the nipple and direct into the baby's mouth. While in picture D, the milk comes out from the glandular tissue and then it hangs around in the ducts, and the baby has now to use more effort. And when the baby is straining, is also going to pull on the nipple and also going to exhaust the nipple pulling the milk from the ducts. Yeah, that is what I'm trying to show you. So proper attaching or latching, the deep latch is very important. That's what we are trying to see. So there are also some breastfeeding positions that are recommended. There's a picture there, is found in most of our manuals, in our breastfeeding manuals. And so those are some of the pictures I found that are approved by UNICEF. At the birth, we recommend this first picture here, where it's just position, the mother is lying, the baby is placed on top. And then we have also the cradle position. And then we have also the cross cradle position for very small infants. This picture, third on the first row. We also have a picture of the mother when we are talking about expressing, that is how you express. We could also breastfeed the baby lying down. There is also underarm position. I also want to mention when a mother has twins, there is it's usually very important to breastfeed them both at the same time. For us who have been experienced in breastfeeding or who have dealt with mother, it is very common that when you're breastfeeding on one breast, the milk on the other breast is also kind of dripping. And we also know that the fore milk and the hind milk, the milk that comes from the breast to begin with, has different qualities with the one that comes from at the end. So we cannot have, when a mother has twins, it's not advisable to take the first baby and breastfeed them and then take the other one. If possible, it's good to breastfeed both of them because they can now benefit from the benefits of the milk from the both breasts. When it comes to more than that, if the mother has triplets or has 4 or 5, now that one is another case. They have to have like a schedule on who is going to, because remember the mother has only 2 breasts. So that's also something to note. Now, very fast, I'll also go through problems that are associated with breastfeeding. These are a common worry for most mothers and for most also supporting the family. As we support our mothers, sometimes we get worried together with them. So the first one is breast engorgement. Now, during the 3rd and 4th and 5th day, that first week, when the milk starts coming in, when now the hormones kickstart, sometimes the milk is so much for the baby. It is so full, the baby is still little with this small belly, and then it cannot now breastfeed them fully. So sometimes the breast becomes so full, they look abnormally swollen, they are hard with fluid, and because they are so full, they are so rounded, such that the nipple disappears. Now the baby even has a problem with latching. So it becomes very uncomfortable. The mother has some discomfort, pain, and sometimes it can even resort to fever. If the mother also goes for a long time, somebody has traveled away from the baby and they have not expressed or breastfed, engorgement is very possible. So the solution is to express. Always start by expressing a little milk from the breast to get the breast to start flowing, the breast milk to start flowing, and then also to allow to release some of the milk so that the nipple at least sticks out. So the baby can now have a latch on. You can also press around the areola to reduce the swelling and to help the baby to attach. Of course, to avoid this problem, breastfeed frequently and make sure the breasts are emptied. And as you breastfeed, you can stroke the breast to help stimulate the milk flow. And before expressing, you can just, the way we do it with some animals, for those people who know how to milk animals, you sometimes use hot water, some warm water to stimulate the breast or the milking. You can use this warm water or warm compresses to stimulate the milk flow before expressing. Now, after you express, because the breast is still having discomfort because of having been engorged, it is advisable to use a cold compress, use a cold cloth over the breast to reduce the swelling and to offer some comfort. Now, when we're in the point of engorgement, sometimes we have breast engorgement of a newborn. you can see that picture there. You should not worry. It is normal. It should not be so much concerned. The first time I saw this, I was also very, very concerned. I wondered. So some mothers may associate their own engorgement and their own breast milk with causing a baby from having engorged. I wish we can, I hope we can see this small picture here. And then before even we see that small picture, when I was talking about engorgement, this is what I mean. If it's a disturbing picture, bear with us because of it. Now you can see this breast of the mother here. It is very, very swollen and red. That is what we are talking about, engorgement. So when it happens in the babies, some mothers can be shocked. The family is also shocked. People say there is witchcraft. It should not be a worrying situation. Sometimes when the mother is pregnant, her maternal estrogens, which circulate in her body, can cross the placenta and enter into the baby's bloodstream, and they can cause similar characteristics in the mothers. And one of the characteristics of estrogen is causing the mammary glands to develop. So a baby, whether it's a boy or a girl, is born now with a bigger, with breast enlargement. Now this one, it clears away when these maternal estrogens that are circulating in the baby also get lowered within about 2 weeks. Then the situation of the baby should worry. Now, when the baby has engorgement, it should not worry the mother as long as it clears within 2 weeks. But if it continues after that, now it becomes a medical condition, she should now be concerned. Another common breastfeeding problem is when mothers experience a sore or cracked nipple. They look like also that disturbing picture there that I've shared. The nipples are tender, painful, and may also bleed. And this problem is caused in very, very big part by improper attachment, improper latching. When we are talking about how baby should latch, when babies just attach to the nipple and they don't have a deep latch, they may cause soreness and tenderness. It looks like that. Now, when a mother has this, she should continue breastfeeding, because if she does not breastfeed, the milk is going to accumulate. It will even bring now engorgement problems, and it could also reduce milk production if she does not produce. So she should continue breastfeeding, but she should make sure that the breasts are not so full, because now it will be more uncomfortable. She should start to begin to breastfeed on the side that does not hurt a lot, to stimulate the milk to come out. She should always have proper attachment and positioning. Now we know what that is, because to begin with, that is what causes this problem. And take care of her nipples. Avoid the skin of her nipples to be too dry or too moist. You know, some products that we use, the soaps that we use, the shower gels that we use, the soaps, some products cause some very dry skin. She should avoid that. Or moist. Some people wear, breast pads, and therefore they become wet with the leaking breast milk, and they do not change them. So make sure that the nipple is always dry and moisturized. One way to make sure that you can moisturize your nipple, using the same milk, express a little milk and apply on the mother's nipple. Even when it is cracked, that is good, because remember, breast milk has some antibodies in them, and it will help in healing the cracked nipple. Now, sometimes nipples, they become sore or they crack because a teething baby, a baby with teething, with its itching on the gum, decides that they can relieve their itching by biting or chewing on the mother's nipple. Anybody who has ever breastfed might be aware of what I mean. And it becomes very uncomfortable for the mother. You are breastfeeding and somebody bites on your nipple. So to avoid this, before the baby is breastfed, if you have a refrigerator, put a wet cloth there, it becomes cold, and then give the baby for it to chew before breastfeeding, and then it will help the baby to have some relief, and they can breastfeed without biting. If you don't have a refrigerator, use cold water. The clothes should be very, very clean. Sometimes the pain is so much so that the mother might have to use a mild painkiller. It should not be over the counter, it should be prescribed, because we should make sure the medication the mother uses is not harmful to the baby. We also have another problem associated with breastfeeding in the breast that affects both the mother and the child. We have the clogged or plugged ducts. Ducts are those small tubes that get the milk out of the glandular tissue that is producing the milk into the nipple. So sometimes the milk backs up. The milk blocks those ducts, and now it blocks, meaning now the milk is not able to pass through. And what happens? The ducts swell. It becomes now a lump. It becomes painful to touch. It's very tender. And sometimes it can be seen as a localized redness. If the problem is not addressed, it could also develop into a problem called mastitis, whereby now the milk that is not passing where the duct is swollen and is painful, it becomes inflamed and it becomes infected with the bacteria. So it causes a lot of pain to the mother in her breasts and sometimes even fever. So it's a very common if the mother is not aware of how to prevent it or to address it. Now, in case a mother has it, the solution is that she has to continue to nurse or to breastfeed from the clogged or infected breast, because to begin with, the milk that backed up, it's stuck in the duct, is the one that is blocking the duct from milk flow. If you do not breastfeed, milk will never be able to get out. So the more you breastfeed, even if it's uncomfortable, and she could also take a mild painkiller which has been prescribed to her by her practitioner to help her cope with the pain, but it is very important that she continues breastfeeding. And it's not worry you that the mother has mastitis or the milk that is coming from there may cause disease to a baby. No, it will not, because actually the baby could benefit. When somebody has an infection, they start forming antibodies for that condition. So the mother, the antibodies are going to be present in her blood and in her milk. So the baby could actually benefit from those antibodies, which they can get through the breast milk. If it's very painful or the baby refuses to nurse, the mother can pump or express, and also applying the warm compresses and massaging the breast could also help break up the clog. When it is available, there is this electric massagers that people have, which is some form of vibration. They could be used on the breast to help unclog the ducts. And always, the mother should visit if there is mastitis, that is the mastitis, the inflammation, and because of the infection, the mother should have antibiotics prescribed for her. And of course, rest, because during rest, healing of the body takes place. Another common one is an infection. It's called thrush. It's also called yeast infection. It can be passed between the mother and the baby during breastfeeding. And what mothers do, they notice a red, shiny, and sometimes flaky nipple. And they may actually, all time, they experience itching sensation and sometimes a very shooting breast pain. On the baby, we are going to notice white patches and increased redness in the baby's mouth, on the tongue, and on the sides of the insides of the mouth as a sign of yeast infection. This yeast infection, in my experience, is very common with cesarean babies and with mothers who have used antibiotics in the course of their breastfeeding, because antibiotics kill also the beneficial bacteria, and this beneficial bacteria keeps yeast levels in our bodies down. So if you use antibiotic, it is possible that yeast is going to grow, the candida is going to overgrow. So the solution is getting an antifungal prescription from a medical practitioner and then putting the nipples and which is put on the baby, on the nipples and also in the baby's mouth. And then you have to sanitize if you are using a pump, you are using all the things that are used on the breast should be sanitized. If it is brush and clothing and towels and anything, wash them daily in hot water and add vinegar, which kills the yeast and the spores of the yeast. Now the thrush looks like this in a baby. There's that picture there where we are saying recognizing thrush symptoms when breastfeeding. You can see the tongue of the baby is white. That's not milk. If you try to wipe it out, it will not come out. So it's very common, and most people don't know. Most people usually assume that it is milk. It's not milk, that's thrush. And if the baby has, we are saying the baby can transmit it to the mother, and vice versa. If the mother has, they can transmit it to the baby. So we need to get treatment for them both. So there are some general guidelines they have put for you. You can also add to what I have said and read them later. And then now, as we finish, because of time, we deal with other breastfeeding concerns. Now, mothers get also concerned about babies who are sleeping at the breast. The baby is supposed to be actively breastfeeding, but then you put them at the breast and they start dozing. So what should mothers do? The mother should start nursing on the fuller breast. You know, all the time, at times there is a breast that is fuller than the other one. So put the baby to the breast that is full of milk, because the milk is now going to be a lot coming in faster. It will keep the baby engaged and alert. So the baby has to be alert because there is a lot of milk that is coming into its mouth. And you can also stimulate the baby. If you see the baby is dozing, tickle their feet so that they can wake up, or sometimes burp them. Stop breastfeeding and burp them and turn them to the breast so that they can continue to breastfeed. And there are some babies who are very sleepy, especially those babies who are born to Syrian mothers who have had anesthesia applied during the operation. Some levels of anesthesia remain in the baby and they are very sleepy for some days after they are born. So we have to wake them. Or for some other reason, some babies are just sleepy. Now, another concern for mother is getting pregnant while lactating. You know, we have heard theoretically that mothers don't get pregnant when they are lactating because of lactation amenorrhea, where there is a cessation of menstruation during exclusive breastfeeding. And note, this is exclusive breastfeeding, and this occurs because of the presence of high levels of prolactin, the hormone that produces milk. As long as there is very high levels of prolactin, then this hormone will produce the amount of another hormone called luteinizing hormone, which helps triggers the release of an egg during ovulation. So the trick here is the mother who is interested in not getting pregnant or who is concerned about getting pregnant, they should get proper information from us who are the practitioners, and we should advise them to exclusively breastfeed a lot all through to make sure that they have high levels of prolactin, which will now inhibit or reduce the levels of luteinizing hormone, which triggers the ovulation and menstruation, meaning now they cannot be pregnant. But if they do not exclusively breastfeed, if they do not for some reason have enough levels of prolactin, then they could get pregnant. So you could also inform mother so that they can know how important breastfeeding is to avoid pregnancy. Then there is also sometimes babies refuse to breastfeed. So it is called nursing strike or breastfeeding strike. For some reason, you give the baby the breast and the baby looks away or doesn't want for some reason. So some of the causes of this is when the mom starts spending time away from the baby, when the mom starts smelling differently, maybe she's using a different perfume, soap or something, when the baby is ill, when the baby has sore gums because of teething, changes of nursing patterns, especially when mothers go back to work and then now they stay away from work, and then in the evening and at night they try to breastfeed the baby. The baby is not happy with the change. Distractions of the baby, sometimes there is a TV, there is some other kids who are visited, or the older brothers and sisters are playing some games or making some jokes. The baby is now more interested in watching the surrounding and seeing what other than the breast. And when there is low milk supply, the baby tries to suck when there is nothing coming out. It's not enough, it gets bored. There is a change of taste in milk. Sometimes when the mother eats, what the mother eats may influence the taste of milk. And sometimes the milk comes in so strong and so fast, especially for a mother who is eating and drinking and who is happy with no stress. She has a lot of, so sometimes the milk is so fast in coming, it splashes on the baby's face, it is full on the baby's mouth, it can even choke the baby. So sometimes the baby gets afraid and they start fearing the experience of breastfeeding. So those are some of the causes. And now, how to address that will be identifying the specific cause of the strike, and then the mother finding solutions. For example, if they spending time away from the baby, make sure you spend time. If it is having too much milk, express some of the milk before breastfeeding the baby so that the baby is not stressed or afraid of being choked. If it is distractions of the baby, find a quiet room, find a quiet moment with your baby. So you find the solution based on the problem. And another concern we have is beverages. Sometimes breastfeeding mother ask themselves, what should they drink? What should they not drink? Is it safe to drink tea? Is it safe to drink coffee? Is it good to drink Coca-Cola? So what we say, here focus on the main beverages that we use here in Africa, that is tea and coffee. And then we want to mention that the information, the theory that is there is moderate amounts are okay. Tea and coffee have caffeine. Tea has tannins, even coffee has amount of tannins, but especially tea has a lot of tannins. Those are substances or compounds that are found in these beverages. Now, excessive caffeine, and when I talk about excessive, it means about more than 300 milligrams. Now, if you tell a mother that, she will not know what that. But I, as a nutritionist or as a breastfeeding consultant or as a professional, I know that roughly 1 cup of coffee has about 96 milligrams of caffeine. Now, that is a lot of information to tell to the mothers. So, and if you tell the mothers, take moderate amounts. The moderate may be when she was not pregnant, she was taking 8 cups of coffee. And now you tell her take moderate, she starts taking 5, which is still more. So, especially when we are working in the local setups, we tell these mothers, avoid coffee, avoid tea. Don't take it, take other beverages, because we are not aware, we are not sure if they know what moderate means. So caffeine found in coffee and tea can pass through breast milk, and it can have some effects on the baby, such as interfering with the baby's sleep, making the baby very hyperactive, fussy, and more irritable. Additionally, the caffeine will also decrease the iron levels in breast milk, and the tannins found in the tea. Tea has a lot of tannins. Actually, they prohibit the absorption of iron from the anything else, even the breast milk. So there could be iron deficiency because a mother is taking tea with her food, and therefore the tea is prohibiting her from absorbing the iron. And if she has no iron in her diet, then there will be no adequate iron in the breast milk. So that one is a problem. So as we conclude, we are having a concern about alcohol. All of us now at this point, we know alcohol is not good. And just to remind ourselves that regular exposure to alcohol, even in pregnancy and in breastfeeding, you know, some mothers are told they can take some alcohol and to relax them because they are stressed. It's not the best practice, because alcohol will end up in breast milk, and alcohol has damage in infant's development. It may cause damage to developing brain or organs such as the liver, and also causes developmental delays in babies, and therefore it has serious effects. And also it decreases milk production because it suppresses oxytocin, the hormone that allows the letdown. So alcohol is not a drink that should even be mentioned for a mother who is breastfeeding. But just in case this mother takes alcohol, and I don't know why she will be taking alcohol, she should wait at least 2 to 3 hours before she is breastfeeding. I know some, let me say, some naughty mothers have had stories when they are traveling, somebody is taking a flight from one part to another or having a long safari, and they have a baby, they are nursing. Some mothers deliberately take some alcohol and then they breastfeed their babies, and the baby now is drunk and sleeps throughout the safari, the journey. Okay, it is going to be comfortable journey for the parents, but they should also know that that is what happens to their baby. Now, spicy foods. Some mothers have been told that they should avoid spicy foods because these foods may cause some effects on babies, including colic, gas, diarrhea, rashes, and breastfeeding. However, there is no scientific effect showing that spicy foods cause problems in breast milk that will cause problems in the babies. Maybe strong flavors may change the taste and the smell of breast milk, so a baby may refuse or accept it more. But when it comes to natural spices and herbs, note, I'm talking about natural spices and herbs, there is no harm in taking them in our foods because they have other benefits for the mother, and these benefits could also be transferred to the child. However, the mother should notice, because babies are sensitive and the mothers, all babies are not the same. Mother should take note that if they eat this food, how did the baby react to the breast milk? If the food is causing a problem, if a spice or a herb is causing because of its flavor or smell, then the mother probably should act accordingly. Eat more or less according to the requirement. Now, I think this is our last. Some mothers are concerned about what effect breastfeeding is going to have on the shape and the size of the breasts. Actually, it is very common. We have heard how true it is. We don't know, but in the developed countries, most breastfeeding is not very, very well taken because mothers are concerned about the shape and the size of their breast after breastfeeding. Otherwise, here in Africa, not unless we change, we are embracing this breastfeeding culturally. It's accepted, and we know that we should expect some changes, and we are happy because at least we are bringing a life and a healthy life. So what can you tell mothers about this? You can tell them the fact is that, yeah, there could be some changes. These changes are not there for everybody. After breastfeeding, both the fatty tissue and the connective tissue in the breast may shift. The breast may or may not return to their breastfeeding size or shape. So here we are saying may or may not be. So some mothers should be told of the expectations. Some may not have changes in their shape or size. Others may have changes, negative or maybe positive. So what women should be told they should do to embrace these changes. And remember, these changes are not only brought about by breastfeeding. So whether you breastfeed or not, there are some things that remain constant, like genetics. Some people with because of their genetics, their shape and the size of their breast will remain the way it is. They are supposed to be even in old age, whether they have babies or not. While others, whether they don't breastfeed or not, the breast will still sag or shrink, whether they have babies or not. And the age, undoubtedly nobody can avoid aging. And as we age, many parts of our body change. So whether you breastfeed or not, some parts are there. And to just help these mothers with their concern, we can always tell them they can improve on their shape and size of their breast, and they can help to reshape their breast after breastfeeding through exercises. Now, if you go to the internet, if you go to a gym, a well-equipped gym and with good, they will have exercises specifically for your chest. Of course, a good diet with a lot of collagen, with a lot of protein, with all the good vitamins and protein, and will help maintain the muscles and the breast tissue. Alternating hot and hot showers, even those people who don't have babies, if they want to maintain the shape and the size of their boobs, they should not just be showering with hot water, because the big part of the breast is fat. So when you use hot water, the fat softens, it's no longer firm. So if it's no longer firm, it's soft. That is how you increase sagging. But if you are showering with that hot water and then you end up with the cold water, it hardens now the fat and that is found inside the breast and on the skin, and therefore the breast may remain firmer. So those are some of the things that mothers can be encouraged to do after breastfeeding, or even when they're breastfeeding. Now, when we are doing breastfeeding supplementation, we said sometimes milk does not come, and the most recommended choice is the human donor milk, or if that is not there, they should have now the newborn infant or the infant formula. Now, animal milk as a breast milk substitute is discouraged. We discourage, and we have been having a lot of problems, especially here in Africa, whereby you go to a certain community and tell them, stop giving the child, do not give the child animal milk, cow milk, because it's not good for them. And they tell you, no, we are ourselves, we were fed on that animal farm milk and we are alive. Even so and so is older than this, also drank that milk. So there are so many disadvantages of the breast milk that are written there, but the fact is it's not the best for the child and should be avoided as much as possible. And among those animal milks, if they must be used, they must be modified accordingly. That is another topic, whereby some parts of water are added to the animal milk based on the age of the child, and it should not be extensive use. The reason I'm saying this, can you imagine a baby has been born? For some reason in the village, there is no infant formula, there is no donor milk, the mother is not there, or there is no milk, and the baby has to survive. Or at least, although it is worst, when it comes to the worst, if there is animal milk, that animal milk should be boiled and diluted with water. When it's a newborn, probably 1 to 1, and the baby at least should be given before now they rush to the nearest center where they can now get formula or other sorts of appropriate milk. So the baby cannot be able to handle the cow milk so well, because there are so many proteins and minerals which are hard for the baby's kidneys, and also the types of fats and proteins that are there are very hard for the baby to digest and may not benefit the baby. So we have come to the end of the session. Welcome questions.
Thank you so much, Annette, for that very, very, very informative session. We do appreciate you so much for that. So from the Q&A bit of this webinar, I do have a few questions here, and I do have a few hands as well that are up. So if you'd like to ask your question live during this webinar, kindly raise your hand and we will allow you to speak. So my first question is from an anonymous attendee who asks, probably this person has a 6-month-old baby or infant who's still breastfeeding, and asks, in case of getting pregnant while still breastfeeding, is the breast milk safe? This is for the one who's still breastfeeding.
Okay, thank you very much, Diana, and for the participant who has asked the question. Now, it is possible to get pregnant when you are breastfeeding. And the first thing she has asked, is it safe to breastfeed the baby, keep breastfeeding the baby? The answer, yes, it is very safe to continue breastfeeding the baby. Although what happens, surely with a pregnancy, the breast milk is going to be lowered. It might not be adequate. The reason is, remember we said in pregnancy, the placenta, which of course develops together with the pregnancy from day one, the placenta starts producing hormones that support the pregnancy. And some of those hormones, there are so many, but I just want to focus on two, is estrogen and progesterone. Now, as long as the mother has these hormones now because of the pregnancy, they are kind of going to downplay the actions of the prolactin. So there is going to be reduced milk production for now this lactating baby. So it becomes unfortunate that the milk produced by the mother who is pregnant will definitely not be enough, especially for longer periods. At 8-9 months, if this mother has become pregnant at 6 months, at 8-9 months, the milk will not be sufficient enough for the baby, and therefore it's unfortunate now that the mother has become pregnant. Because remember, the same resources the mother is using in pregnancy, there is additional caloric and nutrient need for the mother, who is required to have more. And in pregnancy, she also needs additional. So you can imagine now, if she's lactating and she is also pregnant, that is too much for the mother. So it's unfortunate that the fetus is going to suffer a little bit and the breastfeeding baby is going to suffer a little bit, but there is no danger at all in breastfeeding. So that is my answer to the question. And that is why we recommend, we teach a whole topic in maternal and child nutrition about family planning. That is why we encourage these mothers to get pregnant or have the next babies with adequate spacing. I hope that answers the participant.
Yes. Actually, the person has responded, is asking the question from Cameroon and says, thank you so much. As we continue with the next, I have 3 more questions before we get into the live bit of it. I'd like to ask Edna Celestine, prepare yourself with a question, as well as Yakub Mohamud and Ahmed Mohamed Hussein, as well as Hussein Ismail. So prepare yourselves with the questions. Just as soon as we're done with the next bit of the questions, I'll be able to ask you to ask the question. So as for now, we do have one from Abdirizak Ahmed, who asks, please tell me the food increased in milk production during, if the food is increased in milk production during lactation.
Okay, thank you again for that question. Yes, they want to find out if the food requirement, food and nutrient requirement, because remember we eat food provides us with nutrients, the compounds that are called nutrients are found in foods. We definitely require more nutrients and more energy because the milk making process in the mother, it requires more energy, and the nutrients now that are used in making the breast milk is also an additional requirement. Remember, the mother as a being has her own needs, plus the needs of the baby in breast milk or also pregnancy. So actually, if I remember correctly, when it comes to calories, that is the energy, and remember we get energy from 3 macronutrients, that is protein, carbohydrate, and fats. There is an additional requirement. In pregnancy, the mother needs an additional 500 calories. In breastfeeding, the mother needs an additional 300 calories. So definitely there is a requirement to have more food and nutrients. But what people do not know, and what also causes most mothers many problems, is actually overeating. When we are talking about breastfeeding, we are not talking about pregnancy. Now, probably we talk about pregnancy another time. When we say we need an additional 300 calories, that could equate to the normal foods that the mother eats, her breakfast, her tea time, her lunch, her 4 o'clock tea, and her dinner. And then in the additional meal we could give to make sure that she has enough could be one additional meal or drink that is rich in nutrients. For example, 1 nutritious cup of yogurt, 1 nutritious cup of porridge, or, fortified porridge that has been added nutrients in there and has been added some calories in there. Or she could now, as long as she's taking a variety of foods in her diet, the normal meals are enough, and she can now have additional nutritious snacks and liquids. She does not have to change the amount of food that she's eating as a normal woman and a lactating mother, but the quality certainly has to be very, very high. Every meal has to be balanced diet. And then she can now add to her overall diet, she can now add a few nutritious snacks, a few nuts, a few yogurt, a few fruits. So that's all what it takes. So to answer that question, yes, to meet those nutrients requirements, it's not about the food, it's about the quality of the food. The mother has to be fed with a balanced diet from all the food groups, from all the varieties, and then it has to be well prepared in a safe way so that the mother does not get infections. I hope I answered that.
Yes, thank you so much. And the questions are actually flowing in so many. So some of these questions we'll actually have to address them on our community forum. Remember, we have a community forum and we do share information on our webinars on this community forum. We're going to be sharing with you the link to join the community forum. For now, I'd like to welcome Edna. Edna, you can unmute yourself and ask the question. And Edna will be followed by Dominic.
It's among the challenges for breastfeeding, whereby the baby is not able to breastfeed by themselves. And sometimes babies are born too small, especially those who are born prematurely, and they may not be able to breastfeed by themselves. And now my question is, what is the recommendation for the mothers who may become too sick, maybe due to pregnancy complications, or maybe they had an emergency cesarean section and they are not able to breastfeed. And some of these cases, you may find the family is not able to purchase baby formula. So what is the recommendation for that situation? That's my question. Thank you.
Okay, thank you very much. Now I got your question clearly. I'm going to answer very fast. So first of all, you want to know how to deal with the challenge of cleft palate. For those of us who may not be very familiar, cleft palate is when babies have been born and they have a problem with their how can I put it? Their lip and their jaw are kind of connected to the nose, meaning they have a problem with the lips and their gums or their jaws. It is a challenge to breastfeeding. I think you can get that picture where the lip is not there. There's just the nose and the upper lip is not there, even probably the down lip is not there. There could also be problem with the palate, that is the jaws inside there, they are not fully developed. So what we are saying is baby cannot breastfeed. So is a newborn. What can we do to help it? So when this baby is born, we have the mother, we help the mother to express the colostrum, which is a very frustrating process. Remember, colostrum is very thick, and pressing it out of the breast sometimes is not the most successful. It is best sucked out of the breast. But in this case, we are going to try the best and help the mother to express. Remember, it's not much. It's actually counted in teaspoons. It will be 2 or 3 teaspoons, but they are very important and very adequate for the baby. So after this, we're going to have a syringe, a thick syringe, and then we are going to use this syringe to get the baby to open the mouth, and then we are going to press the syringe slowly with a nice flow direct at the back of the mouth, near you press the tongue so that you put the milk there, the colostrum, and the baby is going to be able to swallow. So for the first few days of the baby with a cleft palate, that is how I know we used to feed them when I used to be in that situation where I was working in such a place where we dealt with such babies. We used to use syringes for the first few days, and then the following days now, as the baby develops in weeks, now we start using cup and spoon. We breastfeed, we express the milk, and then we use the spoon to feed the baby. And the baby grows. By 6 months, these babies are now ready for surgery, which are in most setups. Let me talk about here in Kenya. We have camps, medical camps, where we offer free, actually completely free surgery for these babies to encourage them to grow. At a certain stage, we encourage mothers to bring any baby with a cleft palate for surgery. Now, the other question, I hope that is good. When we have, and those are when I started this presentation, I said, today we are dealing with the normal cases, but because you have mentioned about the special cases, when we have a baby who has been born, is very small and is very premature. Preterm babies are born when the time of their gestational period is 36 weeks or more has not reached, so they are small babies. So in most cases, these preterm babies are small and they have not fully developed. They may not even have the stamina to suckle. They may not even be, some of them may have to be kept in incubators so that they can have their respiratory system to develop and other parts. But now, supposing the premature baby has been born and they are in the incubators, that one we do intravenous feeding. No, we not intravenous. We do, what is that other thing? The enteral feeding, where we use some tube feeding and we express the mother's milk if she has any. And unfortunately, if it's very premature, the mother has not yet started to produce enough milk because the hormones that have associated with the production of milk probably have not kicked on. So sometimes we might use a newborn formula, or if the mother is producing milk, we have her to express the milk, and then we do the tube feeding where we do nasogastric feeding. We put the tube through the nose into the gastric system, or sometimes orogastric feeding, we put it through the mouth, through the throat into the stomach. That is called enteral feeding. That is a baby who is preterm. Now, when they get out of the incubator, we now have to help this mother to support. We have to support this mother to breastfeed. We help her to latch the baby. The baby is usually having very weak suckles. They are so weak because they have not yet developed, but it is important to place them on the breast because however little they try to suckle, it stimulates the mother's breast milk, and the skin-to-skin contact obstructing the letdown, so there might be milk that will come out, but the rest of the feeds are still extracted through pumping or expressing, and then we feed the baby now using either the syringe or we feed the baby using cup and spoon, depending on the situation we are in. So there is also a situation where Edna has said a mother is sick and she has developed some complications. We have had cases where during birth the mother has developed some complications. She's sick, she's in the ward, or she's using very strong medication, which she's, for some reason she cannot breastfeed. And the concern here is now the infant. By the way, I don't know. I'm assuming that this mother, if the mother is in the hospital, definitely there will be available newborn infant in the hospital or health center. That is always available. Actually, it is made available by the Ministry of Health in most countries. But now, in the case now this happens at home and the mother is not able to breastfeed and the family cannot afford formula, that is why I said it becomes very, very unfortunate. It is the worst scenario we are not going to wait for the baby to die of hunger. We are going to use what we have. Now, among the animal milks, there is the goat milk, there is the cow milk, there is, I know, camel milk. According to what I know, goat milk is the best. It's not the best. It is, when it comes to its constituents, it is the near one that is near. It is near human milk more than the cow milk. So if we have goat milk and the cow milk, we will use that goat milk. We cannot give whole milk to this baby because the minerals that are there, the protein that are there, the hard protein to digest, the casein in milk, in animal milk is very hard for babies to digest. So what we do, just as an emergency before we get the solution, this should not go on for more than 3 days as we look for solutions, even if it's now fundraising for this baby or something to be done, the baby can be fed for a few hours or 1-2 days with the animal milk, which should be boiled, and then we should dilute it, 1 part of the milk to 1 part of clean boiled water, which should be warmed, and the baby should be given at least to get a little bit of energy and to prevent dehydration. And I've said this should take the shortest time possible before we get the alternative. I hope I have answered. Do we have questions? Is it clear?
Yes, we do. Yeah. Edna, I believe your question was answered.
Yes, very well, thank you.
Okay, thank you so much. So then I welcome Dominic from Sudan to ask his question. As you can see in the Q&A section, we've tried to also address a few of your other questions. But for more information, I kindly request that you do click on the link and join our Humanitarian Global Wave Forum. Hello, Hussein. Yes.
Thank you so much. Good morning. I want to thank here for the Humanitarian Global Institute and my dear facilitator of breastfeeding sessions. So I have 2 questions, and I would like to give me a detail about breastfeeding. The first question is, if the young children below the 6 month up to below 0 month to 6 month refuse to suck the breast milk, what shall we do? Or the other question was, if the child normally wants to suck the breast milk daily 3 to 4 to 5 to 6 once a time in the daily, how can, what is the benefit that child, and what is the benefit of that child for breastfeeding?
Okay, thank you very much. I got the first part of the question. First of all, I'm going to answer that and then you clarify the second part. You are saying the first question, the first is when a child who is below 6 months refuses to suck the breast, what do you do? And we are going to say that if the child refuses to suck, and completely refuses to suck for some reasons, the mother should be supported to express the milk, remove the breast milk manually, and the milk should be fed to the baby. So even if the baby is not sucking, then they will also benefit from the breast milk. And even if the baby is not stimulating the mother's the hormones that produce milk, the action of expressing the milk is going to remove the milk and making sure that the mother keeps on producing the milk. So we are saying express the milk and give to that baby who has refused to suck. Please repeat the second part of the question.
Yeah, the second question was, if the child have needs a lot of milk daily, so and the mother cannot give enough milk, so can we give other foods before the age of 6 months, over the age of above 6 months? What kind of food can we give him?
Okay. Now, If the baby is already over 6 months, it is no danger of course. That is why we now carry out complementary feeding. Complementary feeding means the mother is going on with the breastfeeding, but complementing the breastfeeding with additional foods. So that what you're asking comes under our new topic, another topic that we tackle there in our maternal infant and young child nutrition. We have a full course there, and we cover a topic called complementary feeding. What foods should the babies be given? It's a big topic, but I can tell you at the end of it all, the baby also needs a balanced diet, like the mother. So the baby needs foods from the various food groups. You get food from the cereal, you get food from the tubers, you get foods from the protein, from animal protein, from plant proteins, the fruits, the vegetables. You make sure at least in any one particular meal the baby has 4 of those, four from those food groups. But what do? When you are starting, you don't give all the foods at the same time. You first start with the most easily and digestible. Those are usually carbohydrates. So you start with some tubers, that is some potatoes, some pumpkin, some porridge, or some rice, those carbohydrates that are well cooked. And then you keep on adding. The next, you give them a few teaspoons and then watch for reactions, let the baby get used to the taste. And then after that, you add now another group of food. You add some fruit, a banana there, a pawpaw there, an avocado. You add some protein, When you start feeding the baby the egg and the yolk, you don't give the first time, you don't give the whole egg. You have to separate the yolk and the egg. And then for the yolk, it's more easier to digest and more nutritious than the white. So you first start giving the yolk, which is cooked. Don't give raw yolks. And then the baby is able to digest that. Then you include now the whole egg. You go bit by bit. So to answer you very short, in a short thing, you can say babies are not in any danger if they are not having enough milk at the end of 6, because that is a period where we do complementary feeding, and we can always tackle that under complementary feeding, where we tell you exactly how much and what to give the baby and at what month. So I hope I've answered that. And before we listen to the next question, there is also a question I can see here through the chat. There is somebody called Nicholas Liengo. He's asking, good morning, and he's from Kenya. And he's asked, for those who work in the maternity, there is a drug being prescribed by doctors to initiate breast milk production. They want to know if it is good. Now, I just want to comment here and tell you, nowadays, we have many sorts of people who want to breastfeed and they have no breast milk. We have a category of people who are non-gestational parents. We have people like adoptive parents. You don't have a baby, you are preparing to adopt a baby, a young baby, and you want to experience that thing about breastfeeding. We also have some transgender people. Somebody is tired of being a man, so they have transferred, and now they are a woman, and they are somehow have also adopted a baby, and they have mammary glands. Therefore, they can also kind of want to breastfeed. Now, there is it's very popular, especially in the developed countries. It's not a drug, they are hormones that are given. We said breast production is a hormonal control, and then autocrine control is when the baby keeps on, the local one, when the baby keeps on stimulating the breast, it produces more. That is what we call local control or autocrine. Now the hormonal thing, the hormonal therapy can be given to anybody, even an older mother. We have seen grandmothers who are able to breastfeed. It can be given to men, women now who are previously men, non-gestational parents who have adopted. They start hormonal therapy like 6 months before. They start concoctions of synthetic hormones, the progesterone, all those hormones that I've mentioned, the estrogen, the prolactin, oxytocin, they get a concoction of those. And believe it or not, by the time the baby is being born, and if the baby latch, if the conditions are right, they are going to be able to breastfeed. So it is true that there is hormonal therapy that can be used to initiate breast milk. So do we have another question, or can I read these ones that are there?
I think in the interest of time, you can take one or two from the Q&A section. We've tried to answer as many as we could in the chat section, but you can take, I see there's a few questions, so just take one or two and then we close the session.
Okay, let me answer this one from James Ohisa. He wants to know how serious is the effect of the drugs used in cesarean section, that is anesthesia, in the health of the newborn baby, and how does it affect breast milk? Okay, to answer very quickly, when the anesthesia is injected into the mother or taken by the mother, it's usually gets in the mother's bloodstream. Somehow it will end up in the milk, and when the baby, the effects, you know, those grossness effects, the sleepiness, will also be felt by the baby. So when the mother wakes up from her anesthesia, we place the baby on the mother's breast, because remember, it's very important to initiate breastfeeding early, but there are some traces of the anesthesia used. And so what happens is that the baby ends up having a little bit of it, and so they become a very sleepy baby. These are the babies we are saying we have to keep on waking up, engaging, telling them to wake up. Okay, not telling them, they don't hear, but we have to make sure that they wake up and to try to breastfeed them. The long-term effects of the anesthesia in the babies is not serious, because the amount of anesthesia that goes into the milk is very little. So there is usually just a short-term effect of feeling sleepy, of being under the weather, how the mother was feeling. But long-term effects, if anesthesia was applied by a professional, there has been no concerns. Because mothers are not given the same amount. They are given depending on who they are, according to their needs and the needs of the baby. So in the case you give too much anesthesia, the mother will not wake up. And we don't feed babies from a mother who has not woken up, because it means the anesthesia is still active on the mother. Another question is about what? HIV. During our moderation session, we dealt with HIV, but I can answer this. Some question that somebody wants to know, an anonymous attendee wants to know, how long do you recommend a child born to a HIV positive mother with high viral load breastfeed? Now, first of all, when we encourage mothers to go for prenatal or antenatal care, we do some tests. And one of the blood tests is that done on all mothers is to find out their HIV status. So once we find a mother has a HIV status of a positive, and to make sure that she does not transmit this, we start her on ARVs, antiretroviral therapy, ART. So this one is intended to lower her viral load. So by the time she gives birth, her viral load is expected to have gone down, and this reduces the chances of her transmitting the virus to the baby. So when a baby is born, a newborn, we will never surely know. All the babies that are born are usually positive. But at the end, around the age of 1.5 years, that is 18 months, that is the time we know for sure the status of a baby. So when the baby is also born, they are given baby ARVs to prevent them also from acquiring the HIV from the mother. So you're asking how long this mother can breastfeed. Then the recommendation is just like the normal one. They can continue breastfeeding up to 2 years, as long as they are both on HIV medication, that is the ARVs. The mother is doing something to reduce her viral load, and the baby is taking something to prevent the development of a higher viral load. So with the medication, we encourage mother, because breast milk is the best, to continue breastfeeding as long as possible. But once they are not using the ARVs, then it comes to the end of breastfeeding. I think we can reach there. There are so many questions.
Yes, that we can leave there for today. But in case if you want more of these questions answered, we do have our certificate in maternal, infant, and young child nutrition, which was today's topic. As Annette has mentioned, it's a very, very wide topic. It doesn't just focus on breastfeeding. It focuses on any issue around maternal, infant, young child nutrition, even post once you've had your baby, the kind of nutrition that you do need. And it's not just for young mothers, it's for health practitioners, it's for those of us who are in the humanitarian field, because remember, when you're helping communities, you do encounter young mothers, you do encounter infants, you do encounter young children. And for you to be able to respond to crisis, to deliver aid to these people, it's actually quite important for you to have such a certificate. Like I mentioned, it's not just for our young mothers, it's not just for mothers, it's not just for those health practitioners such as nurses and doctors, it's for everyone working in the humanitarian field. I have been able to share with you a link on the same in the chat section. In case you're interested in undertaking this course, kindly click on that link. It will bring you to this page. And as always, there's a section on this page that asks you to apply now, or you can request a call back and our team will be able to reach out to you and assist you. At this moment, I'd like to say thank you so much to all our participants who attended today's session. Special thanks to all of us who were quite engaging, who asked questions. There were so many questions coming in. Thank you so much to people like Edna, who've also been able to ask their questions live on air. Thank you to those who've shown interest in taking our courses, who've been able to share their details. I also did see that a couple of us registered for the Humanitarian Essentials and Principles course. So thank you so much to those of us. And I look forward to actually you joining this class. In case if you are not able to do so, you can always reach out to us. Our lines are always open. Our communication channels are quite open. And even when you send us an email, we're quickly able to respond to that. You can reach us also via our website with the links that I've been able to share, or the community forum with the links that I've also been able to share. So thank you so much to our participants. Thank you so much to Annette Mambo for having hosted and been the expert who talked so passionately about breastfeeding. I was able to learn a number of things today that I also didn't know. So thank you so much. And Annette is also the one who takes us through the maternal, infant, and young child nutrition course. So she's the expert as well who will be undertaking you through that course, through the moderations. And I really do appreciate the time that she's taken to come and talk to us today about breastfeeding and the issues around breastfeeding. Finally, I'd like to thank the entire Humanitarian Global team. Thank you so much for facilitating this webinar and even other webinars that you do facilitate. As always, we have a webinar every Wednesday from 11 a.m. East African time. Our next webinar will be on procurement next week. So I do welcome you to join this webinar. It's also quite interactive, it's quite engaging, and it's always good to learn something new like we have done today on breastfeeding. With that, I do bid you farewell. Let's interact, let's keep communicating on the Humanitarian Global Wave Forum, as well as through our WhatsApp, through our emails, and through our phone lines, which are indicated in the website as well. Thank you so much, and I wish you a great rest of your day. Goodbye.
My name is Adam Mohammed. I am a humanitarian person and a farmer at the same time. I am also a Nigerian. My journey as a humanitarian started sometimes around 2016 in the NYSC camp. You know, when you finish your degree program, you need to go for a year training. So in Nigeria, we call it NYSC, National Youth Service Corps. So while at the camp, I have this staff of KUSO International. KUSO International actually is a Canadian humanitarian organization that is working towards ensuring no poverty and no equality among the community in all. So they approached the serving corps members at the camp, telling them to come and volunteer with the organization in providing services in certain communities that they will be posted to. At first, I wasn't interested because I am a farmer. Then I realized that there are several areas where I can render my service to. I can also render my service to youths, encouraging them to have a sustainable means of livelihood in agriculture. There and then, I key in, I applied, I became a volunteer. So after volunteering with KUSO International, I then had the interest of working as a humanitarian person. I worked with KUSO International for a year, and thereafter I moved for my second degree studies, Masters in Agricultural Economics at Ahmadu Bello University Zaria. So because of the distance of the place I was rendering the humanitarian service and the place I'm studying, I had to then resign from that particular role. Thereafter, while I was working, I was studying with at Ahmadu Bello University Zaria. Then I also had the opportunity to also volunteer with Action Against Hunger in Borno State. Because of the insurgency, the people in the IDP camp needed humanitarian service. Then I said to myself, I would volunteer to provide that service. After working with Action Against Hunger, thereafter I worked as a farm manager with Agro News Nigeria, and then here I am today working with FX Commodities Exchange, impacting life and providing humanitarian services to the humanity. While volunteering with KUSO International and Action Against Hunger, Feed the Future and all that on other short projects, I then developed that inherent, will I say, likeness of providing humanitarian services to the entire humanity. Then one day I was sitting on my laptop checking through online. Then I decided, I said, no, I need to look at some kind of humanitarian courses that I would attend so I can enhance my skills and my ability to deliver more in the humanitarian sector. So I went online and then I was searching there, and then I came across Humanitarian Global, and then immediately I signed up. I checked the programs that they have. I looked at one particular program that attracted my attention, which is Monitoring, Evaluation, Accountability and Learning, MEAL in short. So I then applied for MEAL program. So generally for MEAL program, I will tell you that it has been superb. Honestly, it has been very, very superb. If there is any word that's higher than that, I will use that. Then for what I have learned, wow, what I have learned actually is too enormous. It's not something I can actually share with you today or the whole of my life. But the things I can then remember that I can share with you is that for MEAL, in short, is part of our lives. In everything you do, you have to monitor, you have to evaluate, you have to account, and you have to learn in everything that you do. If you don't learn, like the famous saying, they say, the day you stop learning, that is the day you start dying. So actually, meal program entails everything that one needs in life. So I have learned a lot. Part of the learning from the program has assisted me in my job today as a humanitarian person. In everything that we do, from the inception of any project, I get involved and then I apply all the learnings that I have there to assist in the development of the basis of the project, how to monitor it, how to evaluate the project, how to get the indicators that will be used to evaluate the project, and at the end of the day to term it as a success or a failure, and also learn from it and how to also account for that particular project. So the learning from meal for me is enormous and is not something that I can share within a short period of time, but I will tell you I have learned a lot.